Good afternoon, everyone. My name is Dr. Prasanth Sadaram, and I'm one of the fellow in Department of Geriatric Medicine in the Institute on Aging at UMS. This afternoon, I would like to talk on myelodysplastic syndrome, also called as MDS. Um, the reason I chose myelodysplastic syndrome is most of the time it is underdiagnosed, and there are some challenges in diagnosing the MDS and also in managing this condition. So I would most of the talk is focused on geriatric perspective of myelodysplastic syndrome. So objectives for this discussion, I would like to begin my discussion with a clinical case. So this is the case I picked from our clinic, and I happened to see just once with one of the attending here. Then I would broaden my discussion by giving you introduction of what is MDS, how to do the workup, and how to risk stratify, and set some of the treatment options we have for MDS management. So this is the case. 72-year-old Caucasian female. She presented to the clinic with chief complaints of fatigue and dyspnea on exertion for a few months. Her past medical history is kind of very extensive. She has hypertension, hyperlipidemia, coronary artery disease, pulmonary embolism, GERD, gastric ulcer, low-grade neuroendocrine tumor of the duodenum, CKD stage 4, lumbar degenerative disc disease, osteopenia, depression, restless leg syndrome, iron deficiency anemia due to the chronic blood loss. And this list is not ending. Social history includes she is a past ex-smoker. She quit 15 years back, and she has a 40-pack year history. She drinks occasionally. It is not quantified. Her family history includes father died of throat cancer, maternal aunt, she had some bone cancer and died of the breast cancer. Her initial workup, abnormal labs have been highlighted here for you to just follow easily. On the CBC, the differential, she has a leukopenia, WBC of 3.85, and she has anemia significant, 7.8. 7.8 is the hemoglobin. Her platelets are normal. Her MCV is on the higher side. She has macrocytosis. On the peripheral smear, she has some macrocytic anemia features with a mild anisocytosis. Her comprehensive metabolic panel is pretty much normal except the BUN and creatinine. Her creatinine is 2.2 secondary to the CKD stage 4, and her liver function tests are normal. Her iron panel studies and thyroid function tests, serum folate, B12, everything came back normal. Her erythropoietin is on the lower side, could be mostly from the CKD stage 4. Because of the bicytopenia and high suspicion for the myelodysplastic syndrome, she is referred to the hematologist. And she underwent a bone marrow biopsy studies, and the marrow suggests of a normocellular for her age and blast count of 2% and some myelodysplastic features. Her fluorescence in situ hybridization, the FISH studies suggest of some deletion of a long arm of the chromosome 20, and she has a trisomy of 5. Her cytogenetics are normal. Finally, she is diagnosed with a myelodysplastic syndrome low grade, with a mild to moderate anemia, currently being managed with erythropoietin therapy. And she is currently following with a hematologist in the clinic. So, first of all, what is myelodysplastic syndrome? Myelodysplastic syndrome constitutes a heterogeneous group of hematopoietic stem cell neoplastic disorders, and it is characterized by ineffective hematopoiesis leading to various degrees of anemia, leukopenia, and thrombocytopenia. And it has an increased potential to develop eventually to acute myeloid leukemia. In most of the cases, the ineffective hematopoiesis leads to compensated bone marrow hyperplasia. And over time, the blast counts increase, and at least 30% of the MDS cases, they develop into acute myelogenous leukemia. It's most commonly seen in the elderly population, and it is a disease of aging. 80% of the MDS cases, they present with anemia and fatigue as the common symptoms. So this is the pathogenesis. As we know, some of the, in MDS patients, the hematopoietic stem cells, they acquire mutations sporadically, and they develop into myelodysplastic clones. And these abnormal clones, they proliferate rapidly and dominate the rest of the bone marrow, lead to ineffective hematopoiesis, and that develops into myelodysplastic syndrome. And in some cases, like at least 1/3 of the cases, over time, they acquire secondary genetic and epigenetic abnormalities, and they progress to acute myelogenous leukemia. All right, how common is MDS? And I want to throw a few facts about the anemia in elderly population. So anemia is very commonly seen in the elderly population, 65 years and above population. At least 10% of the 10% of the population they have anemia, and 1/3 of these cases are secondary to nutritional deficiencies such as B12, folate, iron deficiencies, etc. And 1/3 are secondary to anemia of chronic disease and CKD, and rest of the 1/3 is secondary to unspecified reasons, and among that, MDS is one cause. So MDS overall constitutes 5.8% of the total population with anemia in this group. So it is pretty significant, and we do see these patients in the our regular practice. But the problem with the MDS is most of the cases, they go undiagnosed. Anemia due to MDS, it has some significant features, like it usually presents with macrocytosis and anisocytosis, and sometimes other cell lines can be involved, and it present with the associated neutropenia and thrombocytopenia. So anemia associations in clinical associations of anemia in older population, studies have shown that with aging, there is a normal decline in the normal bone marrow function. And from the Framingham studies, it is shown that anemia increases the risk of falls, and it increases the rate of hospitalizations and prolonged hospital stay. It also impairs cognitive function and physical function, leads to decreased in bone density and skeletal muscle mass. Overall, it increases the mortality rate. All right, moving forward. So coming to epidemiology, MDS incidence is not very uncommon. Based upon the cancer databases, there are approximately 10,000 cases diagnosed annually in the United States. The actual incidence may even go higher. At least 2/3 of the cases remain underdiagnosed. This is the belief, and most of the cases can be missed because in the earlier stages they present with the non-specific symptoms, and because of that, most of them, they don't go for a proper workup. And even though MDS is suspected, some of the cases, they might not undergo definitive testing because of their associated comorbid conditions, and they just left undiagnosed. It can seriously affect the quality of life in the elderly patients, and once the diagnosis is made, the disease progresses over time, and eventually it might be, in some cases, it might be the cause of the death. The incidence usually occurs, the incidence of MDS increases with the age, and median age of diagnosis is 65 to 70 years, and it has male predominance. Overall, 3-year survival rate was of 45%. So what causes MDS? So at least 80% of the cases, we don't know the reason, and it's a de novo, and the incidence increases with the aging. 10 to 15% of the cases, they might have any prior history of some cancer, and might have received some chemotherapy or radiation therapy, and down the road they might develop the MDS, and these come under secondary MDS cases. And so at least 3 to 5 years down the road, after initial exposure with some chemotherapy or radiation, patients have increased risk of developing secondary MDS. Less than 5% of it's a familial and congenital, and the reasons are not known. How do they present? Actually, the MDS cases, mostly they present with the indolent, they remain indolent course. It ranges from the indolent to life-threatening presentation. So most of the cases, they clinically remain very silent, and here and there they present with mild anemia, mild thrombocytopenia, and the workup, initial workup doesn't show much, and they are symptomatically managed or observed for a time. So they they're characterized by various degrees of anemia, leukopenia, and thrombocytopenia. In some aggressive MDS cases, high-risk diseases, it might eventually develop into acute myelogenous leukemia. As I mentioned earlier, 80% of the MDS, they present with anemia, and which is the major cause of the morbidity. This anemia even worsens the underlying comorbid conditions like presence of any CHF, COPD, hypothyroidism. All this increase the morbidity of the underlying other comorbid conditions. The symptoms, usually they present with the fatigue, shortness of breath and exertion, and syncope, etc., which can mimic the symptoms from other comorbid conditions. And people who are like severely anemic, they might eventually end up with requiring multiple blood transfusions. People with patients with severe thrombocytopenia, they might present with some bleeding and bruising, and 10% of the population end up with the serious bleeding, like gastrointestinal bleeding, bleeding into the brain, intracranial bleeds, etc. Some group, they might have recurrent infections secondary to the neutropenia as well. And on physical examination, in 10 to 15% of the cases, we might appreciate presence of hepatosplenomegaly, and 5 to 10% of the cases on physical examination, we can appreciate the presence of lymphadenopathy. So once an MDS is suspected, we need to work up for the diagnosis, and this is a workup. We do the CBC with the differentials, where we can find presence of cytopenias and some dysplastic changes. Comprehensive metabolic panel, reticulocyte count, peripheral smear, where we can see the dysplastic changes. Iron studies and B12 and folate, all these nutritional deficiencies should be ruled out. And infectious causes leading to the bone marrow suppression, such as HIV, Epstein-Barr virus infections, hepatitis B and C, should be ruled out. So basically, MDS is diagnosed after ruling out all the most common causes. For definitive diagnosis, bone marrow studies should be done, and on the bone marrow studies, we need to look for presence of dysplastic cells and the presence of any blasts. And cytogenetics also should be studied, and along with the MDS panel, the fish study should be studied. So these fish studies and the MDS panel can show if there are any karyotypic abnormalities which determine the prognosis for the MDS. Once the diagnosis of MDS has been established, certain additional tests can be performed. For instance, human leukocyte antigen typing should be done for patients who are good candidates, or for candidates going to hematopoietic stem cell transplantations. And other causes of the anemia and close mimickers of MDS should be ruled out, such as large granular lymphocytic leukemia and paroxysmal nocturnal hemoglobinuria should be ruled out. And once again, this is the diagnostic criteria. Presence of any cytopenias associated with some MDS features, like a presence of dysplastic cells, presence of blasts, abnormal karyotypes, and abnormal MDS-related mutations, and other causes of the cytopenia should be ruled out. Basically, presence of any copper deficiency, alcohol abuse, and certain medications should be ruled out. Certain medications can cause bone marrow suppression, such as methotrexate, azathioprine, and recent chemotherapy. These are also need to be ruled out. Look for any autoimmune conditions, such as idiopathic thrombocytopenia and systemic lupus erythematosus. And other close mimickers of MDS, such as aplastic anemia, myeloproliferative disease, all this should be ruled out. Once MDS has been diagnosed, WHO has actually classified the MDS into subtypes. It basically looks into number of the cell lines involved, presence of dysplastic cells, presence of abnormal cells like ring sideroblasts, etc., and the presence of any percentage of the blasts. So we have MDS with a single lineage dysplasia where one single lineage is involved. MDS with ring sideroblasts where there are abnormal ring sideroblasts in the bone marrow are present. MDS with multi-lineage dysplasia with the involvement of multiple cell lineages. MDS with excess blast 1, where the blast count in the bone marrow is ranges from 5 to 9%, whereas blast stage 2, the blast counts are in the bone marrow ranges from 10 to 19%. MDS with isolated deletion 5q. This group actually presented with the anemia, and they respond very well to the treatments like lenalidomide. And MDS with excess blasts in transformation. This is the group which is at a high risk of transformation to the AML. It has blast counts of 20 to 29%, and some plus or minus some errors. All right. So once the diagnosis of MDS has been made, the next question is, what is the prognosis of the patient? So prognosis of the patients with MDS can be calculated using a number of scoring systems, such as International Prognostic Scoring System, the revised version of International Prognostic Scoring System, and some WHO IPSS combined scoring system as well. The IPSS revised scoring system is widely accepted as a valid tool to measure the prognosis, and these scoring systems take into consideration several parameters like the number of cytopenias, percentage of the blasts in the bone marrow, and presence of any cytogenetic characteristics. And it provides a tool to measure the probability of survival and also the risk for progression towards AML if they left untreated. Although not systematically incorporated into these new validated prognostic systems, presence of somatic mutations actually can define the prognosis. And for instance, any patient who has somatic mutations, they have worse prognosis compared to groups which doesn't have the somatic mutations. In addition to the biological and clinical properties of the MDS, the treatment becomes significantly complicated in the older patients due to presence of their other comorbid conditions and the difficulties in accessing to the medical care, and so their social situations and their cognitive status, and also declined functional status. All these factors can affect the outcome and management of the myelodysplastic syndrome, and it becomes a challenge to deal with MDS in elderly population. Once again, International Prognostic Scoring System, it takes into consideration certain parameters like a presence of blasts, karyotype, and cytopenias. And the score is computed, and it gives risk stratifies the MDS groups, MDS into low risk, intermediate 1 and 2, and high risk groups. Studies have shown that low risk groups, they have overall better survival, and less number of the patients can actually transform into AML, whereas high risk groups, they have very bad prognosis, and they have less survival rates, and also they progress to AML at the earlier stages of the disease. And this is the revised version of IPSS. It's basically same as IPSS original scoring system, but it takes into consideration the depth of cytopenias, and it gives the score, and based upon the score, their risk is stratified into very low, intermediate, high, and very high groups. So once we have the risk stratification, we can get an idea about the survival, and also percentage of the chances of AML transformation. For instance, very low risk group, the median survival is 80 years, and there are less chances of progression to AML. Whereas a very high risk group, the median survival is 8 months, and they have very high chances of AML transformation at the early stages of the disease. All right. So this is the MDS mutation profile, and mutations associated with the MDS has been studied in the past, and it was found that presence of any of these mutations, ASXL1, EGH2, RUNX1, ETV6, and ATP53, presence of these mutations defines bad prognosis. 30% of the MDS patients have a mutation in one of these genes, and these mutations indicate a more severe disease. All right. So as I mentioned earlier, somatic mutations can, by themselves, can predict the prognosis as well, on top of having the IPSS scoring systems. So here, the impact of mutations by the IPSS groups. So the presence of mutations will add to the poor prognostic outcomes, and presence of the mutations will actually upstage the risk in any given group. For instance, if you can see here, this is the normal survival or prognosis in low risk group in the absence of mutations, and this is the intermediate group survival. So IPSS group, IPSS low risk group, in the presence of mutations, the survival, you can trace it down, and it actually behaves like as it is like intermediate group. So in summary, the presence of mutations will actually upstage the risk in any given group. Summary of the MDS risk stratification. So we have low risk categories. These are this group includes a very low risk plus or minus high risk somatic mutations, and also very low intermediate with the presence of SF3B1 SM mutations. And these low risk groups can be managed supportively, whereas high risk groups, which includes presence of 3 or more high risk somatic mutations, presence of TP53 and complex monosomy karyotype, and very high and high risk IPSS revised scoring system. This high risk group usually benefit from the bone marrow transplant, and intermediate risk groups, the treatment is completely individualized, and other parameters should be taken into consideration, and holistic approach in management of MDS is needed. Summary of the MDS genetics. So we need to know that pre-malignant states can also exist. So these are very common and age-related. These pre-malignant disorders, for example, CHIP and CCUS. CHIP defined as a clonal hematopoiesis of indeterminate potential, and CCUS is a clonal cytopenia of undetermined significance. So these are pre-malignant states, and the risk increases with the aging, and they increase the risk of hematological malignancies, and increases the overall mortality. And presence of these mutations, TP53, EGH2, ASXL1, etc., presence of these mutations predict a bad prognosis. And ETH2 mutation, presence of ETH2 mutation defines that it defines the sensitivity to the hypomethylating agents. So presence of a TP53 mutation groups, MDS groups, can be treated, can respond very well with the hypomethylating agents. Whereas the presence of TP53 and DNMT3A, these are the poor prognostic mutations, and they have poor outcomes with the following the bone marrow transplant. All right. So the treatment options for the MDS, we have multiple treatment options for the MDS, and the treatment is basically risk adapted. All right, moving forward, the treatment of MDS. So the treatment, there are many treatment options for the MDS, and it is basically depends upon the risk. It is basically risk stratified. So the low risk groups can be observed for over time, and it varies from observation and some transfusions, and in the high risk groups, mostly they go for the stem cell transplantation. All right, this is the treatment algorithm for the low risk group management. So the primary goal for low risk MDS cases is to improve the numbers hematologically, and to improve the symptoms, and also the aim is to improve the quality of life in general. The early stages of low risk disease just can be managed by simple observation. They usually present with anemia, like mild anemia, mild thrombocytopenia, and they might remain asymptomatic for most of the time. And as the disease progresses, and they might end up requiring some transfusions of PRBC and the thrombocytopenia. And sometimes if they become too much dependent on the transfusions, we can even try the erythropoietin stimulating agents. And when the erythropoietin stimulating agent if they don't have any response to the erythropoietin stimulating agents, we can add granulocyte colony stimulating factor, because studies showed that there is a synergistic benefit with the erythropoietin stimulating agent and colony stimulating factors. Patients who have 5q deletion genes, they can respond well with the lenalidomide in the absence of other cytogenetic abnormalities. Again, patients who have 5q deletion in the presence of other cytogenetic abnormalities like high risk somatic mutations, they do not respond very well with the lenalidomide. It is a pure 5q deletions. MDS cases have showed a good response to the lenalidomide. If they fail to the lenalidomide, the treatment is pretty much either offering the hypomethylating agents, or it can they can even be managed with the immunosuppressive therapies. So erythropoietin stimulating agents, these are the first line of therapy, and commonly we can use recombinant human erythropoietin or darbepoetin alpha. The response rate to the erythropoietin stimulating agents have been studied in the various MDS cases, and currently we have some predictive scoring systems which can tell the likelihood of response to the erythropoietin stimulating agents. So people who have low serum erythropoietin levels and who are less transfusion dependent, they respond well with the ESA agents, whereas people who have high erythropoietin stimulating serum erythropoietin levels, they do not respond well to the ESA agents. And one thing to keep in mind with the ESA agents is that they can worsen the renal function, so it is important to monitor the renal function while they are receiving the erythropoietin stimulating agents. All right. Several phase 2 and phase 3 trials have shown that clinical synergy of erythropoietin stimulating agents when combined with the granulocyte colony stimulating agents. So this is a normal. This is a survival curve, survival benefit with the erythropoietin with the granulocyte colony stimulating factor. Whereas untreated patients, they don't have a better survival compared to the treatment group. It doesn't actually affect the the progression to MDS, so there is no benefit in terms of the MDS progression. All right. So most of the MDS patients who fail with the few blood transfusions, and eventually as the MDS progresses, they might end up with requiring multiple blood transfusions. And this group of patients who are requiring multiple transfusions can eventually develop secondary iron overload stages, and overall these patients have a shortened overall life expectancy. So you can see here the level of transfusion dependence is determines the prognosis in MDS. So the more the PRBC transfusions, the less the survival. And also serum ferritin levels can correlate overall with the MDS survival. So ferritin levels less than 1000, they have better survival compared to the ferritin levels above 1000. And so these patients, iron chelation therapy has also been tried in the MDS patients requiring too many blood transfusions. And so we all know that in patients with the congenital disorders like thalassemias and hemochromatosis. These are the transfusion-dependent transfusion-dependent conditions, and they end up in iron overload stages, and iron chelation therapy in these conditions showed several benefits. So studies, retrospective studies have been conducted in the myelodysplastic syndrome cases who are transfusion dependent, and studies showed that iron chelation therapy, the group which are requiring the iron chelation therapy did well compared to the group not requiring the receiving the chelation therapy, but it doesn't have any effect on the AML progression. All right, Telesto trial. So this is a randomized controlled trial, prospective trial, and it is conducted in Italy, and it is published in 2008. So it basically compares a group which is receiving the deferasirox and compared to the placebo group. So patients getting the deferasirox have a better event-free survival compared to the placebo group. When they don't respond to prior therapies, we can look for the any cytogenetic abnormalities such as karyotypic abnormalities like 5q deletions, and MDS cases with the 5q deletions, they respond very well with the lenalidomide. Studies have lenalidomide is a second generation immunomodulatory drug. It is basically an oral agent and can be managed in patients in the outpatient setting. Patients need careful monitoring of the blood counts, and sometimes sometimes they can be managed with some supportive transfusions here and there. And studies have shown that in patients with the 5q deletions with no other complex karyotypic abnormalities, 67% of the patients have become transfusion independent, and the response lasts for more than 2 to 3 years. And patients with the erythroid or cytogenetic responses to the lenalidomide treatment had significantly lower rates of progression to AML than those who did not respond. Some adverse effects need to be observed here. So lenalidomide has been associated with, sometimes with the severe neutropenia and thrombocytopenia, and it also has increased risk of thrombosis. One key thing we have to keep in mind is that 10 to 20% of the patients with the 5q deletions can sometimes harbor other additional mutations. For example, presence of TP53 mutations on top of the 5q deletions. This group may need aggressive treatment, and they might end up receiving hypomethylating drugs and even going for the stem cell transplantation. All right, so these are the treatment guidelines in managing the high-risk MDS groups. So the high-risk MDS groups, the primary goal is to for the curative therapy for the MDS, and high-risk group patients. The focus is here is mainly to modify the natural course of the disease and extend their survival. And there are many different new therapies came into the market, which includes which can range from low intensity chemotherapies, immunomodulators, and also may to enhance the hematological improvement, and also to decrease the rate of leukemia transformation and improve the overall survival. High dose chemotherapy followed by hematopoietic stem cell transplantation is presently the only treatment with a curative potential in MDS, and 40% of the patients may be cured with the hematopoietic stem cell transplant, but advanced age, presence of other comorbid conditions, and procedure-related risk factors, and lack of donor availability, all this will are the limitations in for getting the hematopoietic stem cell transplantation. So patients with the high risk groups, if they're transplant candidates and if they have the donor availability, they can get the hematopoietic stem cell transplant. If there is any relapse in the disease, they can be enrolled in the clinical trials or maintained on the hypomethylating agents. And patients who do not, who are not candidates for the transplant, they can be they can be managed with the hypomethylating agents, or high intensity chemotherapy or enrollment in the clinical trials. All right, going into individual treatment, individual therapies. Hypomethylating agents. In MDS, hypermethylation is the problem. So hypermethylation of the cytosine residues on the DNA and consequent chromatin condensation are the key features of malignant phenotype. And this leads to epigenetic silencing of the genes involved in control of the normal cell growth and differentiation. So the hypomethylating agents such as azacitidine and the dacidobine, these are developed to maintain the genome in the hypomethylated state. So both these drugs they incorporate into the DNA and they cause a hypomethylation, and azacitidine preferentially causes the DNA damage and induces the apoptosis. In high risk MDS, the hypomethylating agents should be tried at least 4 to 6 cycles, and if there is any hematological response, the survival is usually lasts for more than a year, and treatment should be maintained for rest of the time, for significant amount of years. So, as I mentioned here, the response rate takes at least 4 to 6 cycles. So, we have to give enough time for the response to see the response, and premature discontinuation of therapy, thinking treatment is ineffective, can lead to erroneous conclusions. If there is no response with the hypomethylating agents, they can be enrolled in some clinical trials or supportive therapy. And also, these hypomethylating agents can be an option in patients who received the bone marrow transplantation. All right. So internationally, there are multiple phase 3 randomized trials have been studied, and they compared the 5-azacitidine with the conventional care in patients with the high risk MDS groups. And overall, the overall survival in the group receiving the azacitidine is 24 months compared to the conventional care, it is 15 months. And the 2-year survival is 50% in the azacitidine group compared to 26% in the conventional care group. Hypomethylating agents, some clinical pearls with the hypomethylating agents. Azacitidine can also be considered as a maintenance therapy after the hematopoietic stem cell transplantation, as I mentioned earlier. And azacitidine and dacidobine, these are not the perfect drugs, and the oral response rate is only 45%, and the clinical response rate is 15%. The response takes at least 4 to 6 months to appear, and the counts can initially get worse, and over time they improve. Hypomethylating agents are generally well tolerated, like when compared to other high intensity chemotherapies. These are well tolerated, and they have less anti-emetic, less emetic potential, and the hair loss and mucositis are not really a big factor here. The response rate is highest in patients with the TET2 mutations. As TET2 mutations, they respond well with the hypomethylating agents, and MDS cases with the ASXL1 mutations, they do not do well with the hypomethylating agents. All right, immunomodulatory treatment for the MDS, medications like anti-thymocyte globulin, cyclosporine, and alemtuzumab. These medications are these options are limited to very small group of the MDS population. Mostly it's it's used only in the 5% of the MDS cases. The better responses are seen in patients who are actually younger groups, less than or equal to 60 years, having a HLA-DR15 and short duration of transfusion dependence. And dependence on whether there is a immune component in the to the marrow failure is also determines if they will be responding to the immunomodulatory therapies. And most effective in the early phases of the MDS, and secondary MDS and rare refractory anemia with the ring sideroblast are non-responsive, while trisomy 8 disease appears favorable. And SF3B1 mutation was associated with a poor response to the immunosuppressive therapies based upon the studies. All right, allogenic stem cell transplantation. Allogenic hematopoietic stem cell transplantation remains the only curative option for the MDS patients. The cure rates vary from 30 to 40%, and 20% of the patients live for more than 10 years. And transplant-related mortality is almost 20%. So, and transplantation is also, it's not a safe procedure. It's not a benign thing. They might even end up with having a graft versus host disease, which is a really very concerning patients going for the transplantation. For intermediate to and high risk MDS, earlier the hematopoietic stem cell transplantation, the better the overall survival. And as I mentioned, presence of TP53 mutations, they have poor survival compared to the groups who do not have the TP53 mutations. And the relapse also, presence of TP53, the relapse rate is higher compared to the absence of TP53 mutations. And studies were published earlier regarding the stem cell transplantation. So patients with the TP53 mutations has a median overall survival after the transplant is less than a year, and it has a high relapse rates. Patients with the in patients who do not have TP53, TET2, or DNMT3A mutations, they have a better prognosis after the bone marrow transplantation. All right, conclusion. So, in summary, assuring accurate diagnosis and obtaining the comprehensive baseline workup is the first step in the MDS management. Accurate risk stratification is important to tailor the therapy. In low-risk MDS groups, we can try ESAs, lenalidomide, immunosuppressive therapy, and hypomethylating agents. In high-risk groups, the allogenic bone marrow transplant should be considered, and along with the hypomethylating agents. So these are the standard of care. MDS cases who do not have TP53, TET2, or DNMT3A mutations, they have better prognosis prognosis after the transplantation. Patients with the TP53A mutations are better served with the hypomethylating agents and enrollment in the clinical trials than intensive chemotherapy and the bone marrow transplantations. All right, thank you so much. Thanks for the opportunity, and I wish you all stay safe from COVID-19 virus. Thank you. Bye-bye.